Thank you all. As you all know, the International Fund for Promoting Homeopathy is conducting regular sessions from 7 to 10. 7 p.m. we have our Hindi session, 8 to 9 we have our international session in English, and 9 to 10 we have our local language session in Malayalam. Today, our guest is Dr. Sumana Kumari Panda, and she is an MD holder, and she is the DMO of Cuttack Department of Homeopathy, Government of Odisha. And she has an experience of more than 35 years, something great, because she not only has the experience, but she is sharing her experience. That is something that we should congratulate for her for these sessions. And she had already presented some of the best papers in our forum recently, and she has become another experience of 18 years in teaching at the Department of Veterinary Medicine at Dr. Abin Chandra Homeopathic Medical College Hospital, Bhubaneswar. And she has experience of working in research and worked as the principal investigator in collaborative research projects under CCRH Government of India efficacy of homeopathic therapy on during labor. And she is one of the resource person in various medical field, and she has done a lot of scientific presentation in different part of India, and particularly an LIGH, IFPH Research Society of India, so many presentation in different part of Tamil Nadu, Andhra Pradesh, etc. She has written article published on peer. Her articles were published in peer journals like IJRH, etc. She has awarded some of the best awards from Orissa as well as nationally. The Hanuman Pravida Saman in 2014 by Homeopathic Board of Odisha, and best homeopathic COVID barrier in medical Marwadi Mahara Samaj, as well as best written social worker. She has best woman social worker by Odisha Nari Seva Sangha Cuttack, etc. And she is today presenting a case study of infertility due to PCOS with hyperprolactinemia. So let us begin the session with a beautiful evening. Let us invite Dr. Sumana Kumari Panda to the session. Welcome, madam.
Thank you, Dr. Dhanesh, for introducing me. Good evening, everyone.
Yes.
So coming to my session, really the same session I have conducted in Hindi language yesterday, and today is in English session. So the same topic, on the same topic. So I am sharing my screen. So coming to the subject particular, that is PCOS associated with hyperprolactinemia and infertility, a case report. Really, this case report I have presented in 74th Liga International Seminar at Sorrento, Italy in 2019. So, and that this study was highly appreciated, and the paper was where the chairman was our Dr. Manchanda was the chairman in that session, and someone else from Europe, and the paper was highly appreciated in that seminar. So today I am going to present that paper only. So PCOS associated with hyperprolactinemia and infertility, a case report. Usually we find PCOS is usually associated with PCOD associated with other hormonal changes. When happens, we call it as PCOS.
Madam,
So,
little more sound, and sound is if possible.
sound.
Okay, otherwise you can go ahead with the same. No
Am,
problem.
am I audible now?
Yes, yes.
Okay, thank you. So coming to PCOD, polycystic ovarian disease. Polycystic ovarian disease is the biggest threat nowadays in 21st century, and what we find everyone might be well accustomed with this type of cases nowadays. I remember in 90s in my clinics I used to get a PCOD case, not PCOS. PCOD case once in 4 5 months like that, yeah, 3 4 months like that. But nowadays every alternate day we can say that we are getting a case of PCOS, not PC, not only PCOD. So PCOD when associated with other hormonal changes, other complications, that is known as PCOS, that is a syndrome, that becomes a syndrome, might be associated with a hypothyroidism, might be associated with a hyperinsulinemia, might be associated with a hyperandrogenism, or in some cases also we find there is anovulatory cycles, and the clinically we may find the features of hirsutism, the obesity, all these things. So various factors are responsible for this. Okay, so if we will come to the factors, why in 90s the incidence was so less, and why it is now it is so more. So we will find the change in lifestyle, though genetic preponderance is there. Genetic effect, the extreme weather effect, heat stress effect, food and water consumption effect, the lifestyle has changed. Change of food, change of diet. We have well accustomed with the Western diet style, and exercise is becoming very less nowadays with the young generation, and the sleep habit also changed too much. Usually most of the young generation girls are going to sleep after 12, might be 2 a.m 3 a.m like that. So that is also creating an havoc. So what to we have to change our lifestyle. The stress is too much due to work pressure, the family pressure. So everywhere there is stress. So that also affects these things, the change in diet habit, change in sleep habit, mental stress, inactivity, the activity level reduced. So all these factors contribute for the hormonal disorders. Might be diabetic, might be hypothyroidism, might be in young generation PCOS. So polycystic ovarian syndrome uh, is a major threat in 21st century, and it is in rising trend. So that has caused a headache. This is a headache. Everyone, with the parents, with the relatives, with the doctors. We doctors are much taking much more headache for these PCOS cases, because this PCOS most of the time tends to infertility, and the incidence of infertility also in increasing trend in the society. So one of the most common hormonal disorders among women of reproductive age is PCOS, and most common and complex endocrine disorder in the women worldwide. Next, coming to what is PCOS. So polycystic ovarian syndrome is a heterogeneous disorder of unknown etiology. Now, it is of idiopathic origin, though genetic factor dominates, but it is not only the genetic factor which causes PCOS. So PCOS is a multifactorial disorder with various genetic, endocrine, environmental abnormalities, which is a common cause of infertility and of pregnancy complications. So how to diagnose PCOS? We can diagnose, the latest diagnostic criteria is the Rotterdam diagnostic criteria. In the International Gynecological Conference at Rotterdam in Netherlands, so was held, and in that uh, conference, it was concluded that the some of the factors they have given the three criterias. Out of three criterias, if two are satisfied, then we can term it as polycystic ovarian syndrome. And those criteria is known as Rotterdam diagnostic criteria. So number one is oligo ovulation or anovulation. Ovulation is there, but the maturity level, the rupture of the ovum is not satisfactory. So it is oligoovulation, and anovulation there is no matured follicle and no ovulation. Next, number two is a hyperandrogenism. Hyperandrogenism, the androgen level is increased, the testosterone level is increased in the serum. So how to know? We may know this by biochemical, the blood investigation. Otherwise, we can know clinically. How to know? The clinically, we may find the hirsutism, the mustache, the beard in ladies, or the male type of baldness we may get. So clinically also we can diagnose hyperandrogenism, or through lab investigation we can know also biochemically this is a hyperandrogenism. Next, so to go for blood investigation, the suitable period is during menstrual period, during day 1 to day 4. Within day 1 to day 4, if we are going for the serum and test for testosterone, if it is increased, then we can term it as a hyperandrogenism. So next, now number 3 is polycystic ovaries on ultrasound. On ultrasound, we may get polycystic ovaries. So if out of three criteria, if two are satisfied, then we can diagnose as PCOS.
Excuse me, ma'am. Ma'am, this is Dr. Neha Kakkar. Ma'am, can you please, put the slides on the slideshow mode so the doctors can see the slides more clearly, ma'am? Because
Okay,
some
I'm
people are
trying.
not able. Yeah, you can
Okay,
click on
okay.
it. Yes,
Yes,
ma'am.
yes. Is it visible now clearly?
Um, Not yet, ma'am.
I am in slideshow mode.
It's not showing on your in the. Click on
I
the.
I can see in the
Or
slideshow
you
mode.
you can just zoom in your thing.
Yes, I have zoomed.
Oh, but it's still not visible, ma'am.
So
I guess then the doctors can, zoom the slides on their laptops or on their mobile phones itself. Then you can see the slides clearly. Yeah, if ma'am is not able to do that, maybe there is some problem technically. So the doctors can zoom their own slides on the laptops and on the mobile. Then that will be clear.
yes,
I
in
hope
every
this.
session usually this is happening. I couldn't show you the complete in full
It's okay,
screen.
ma'am. It's okay. You can continue, ma'am. Thank you.
Ma'am, there is the under the left side corner. There is a
Yes,
one.
yes, yes, yes. I have on that slideshow mode, but
Yes, you have to make it. There is a plus point, plus mark, and you have to remove slightly slide the corner of the bottom corner, left corner, left not right corner.
yes, sir. I have made in slide.
No, there is one making the, we can make it big. The corner, there is one
No,
slider
no,
you can see.
no, doctor. On the top, you can see home. Then you can see if you just concentrate on the top level. There you can see home. Then you go to the right. Then you can see this. After some three, four. The fourth option is slideshow. Just go on the line. Keep on the line. Just next one. Next one. Next one. You just click on the next slide. That is a slideshow. Yes. Now you click on that.
Oh, from current slides. Okay.
No, you just went away again. Just click on the top.
Yes, from the top I have done. Is it visible to you?
We can see, but the thing is that it is not a full screen, but you can see the side thing also on the side. So if you go in that way, you can.
There is you can see there is 60% at the bottom right side corner. 60%. Then you can slide it. Yeah. Go to that area. Yeah. Okay.
So next we have to go to current slides.
Yeah. Now it is big.
Is it visible to you?
Yeah.
Yes, ma'am. Now it's okay. Yes, ma'am.
Okay. Thank you. Okay. So coming to incidence, the exact prevalence of PCOS is not known as the syndrome is not defined precisely. But the prevalence of PCOS is a highly variable, ranging from 2.2% to 26% globally. What a huge variation. Few studies conducted in India, that studies done in South India and Maharashtra, prevalence of PCOS by Rotterdam's criteria were reported as 9.13% in South India and 22.5% in Maharashtra. So you can mark the lifestyle of South Indian people and the Maharashtrian people are somehow different. The work stress, the inactivity, the sleep habit is very uh, is not normal, is not disciplined, not so smooth in Maharashtra. So that's why it is increased. The incidence is so much increased. 9.13 and 22.5%. So there is a huge variation between the South Indian states and the Maharashtra. So that's why it mostly the environmental factors, the lifestyle factors are very much related to PCOS. So coming to the case report, really in this case I must mention that the environment I had told you that the sleeping habit, the diet habit, the environmental factors like inactivity, the weather changes, and the all these stress, mental stress are major factors. But I should not forget to say that the plastic use of plastic bottles, the plastic containers are also contributing to the development of PCOS. How really I have presented this paper on this subject in Indian Climate Congress in one seminar, that the plastic, there are some components inside the plastic, they behave like xenoestrogen. So when we are using too much of a plastics, and if we are taking hot food inside the plastic containers, hot drinks inside the plastic containers, then that contributes a lot the xenoestrogen, and the xenoestrogen behaves like a natural estrogen. That's why the higher estrogen level when continues, that contributes to the anovulatory cycle and subsequently to the infertility and to the PCOS also. So plastic has a very good role in for contributing for PCOS. So coming to the case report, a 21-year-old unmarried girl reported at Dr. Avin Chandra Homeopathic Medical College and Hospital OPD in my OPD that Bhubaneswar with a clinical history of delayed menses for last 3 years on dated 14th April 2011. So she had a history of 3 years of delayed menses, her irregular cycles. Mostly the cycles at the interval of 60 to 70 days for last 2 to 3 years and flow for 2 to 3 days. Pain lower abdomen. She had the next presenting complaint was unusual milk secretion from breasts, recurrent headache, chronic constipation, and difficult soft stool. So these were the presenting complaints. Next, coming to modalities, headache aggravation in morning after rising up, worse from anger, thinking long time, exposure to heat, head bath, and relieved by mental relaxation. So these are the modalities found in that case. Coming to physical examination, she was obese, and according to her statement, that in last 3 years she gained 10 kg weight. Her BMI was 26.6. As we know, the normal BMI ranges from 18 to 24, and 25 to 29 is overweight, and 30 onwards, and that is obese. And she had 26.6. So she was coming under the category. No, obese is 25 to 29 and 30 onwards overweight. So she was coming under the category obesity. Ultrasonography she brought to us on 28th March 2011 revealed anovulatory cycles with retroverted uterus and endometriotic mass. Blood investigation she brought us, that is the serum prolactin was 35.88. Really this is a case from a referred case from a professor in gynecology. So she has undergone all investigations and the ultrasonography during her treatment with those that gynecologist, and finally she that gynecologist referred the case to the homeopathic doctor and she came to our OPD. So TSH, thyroid stimulating hormone, was 5.16 with a higher borderline on dated 25th March 2011. Really normal TSH level you will find that 0.35 to 5.5. But many studies are there online. If you want to read, you may read that the many studies say that in young age, the unmarried girls, the good TSH level is within 3.5. If it is within 2.5 to 3.5, it's very good. So, and she had 5.16 for her age, that was coming under higher borderline. Coming to physical generals, hot patient but susceptible to cold, craving for salt, fried food, non-veg, rich food. Bowel was constipated, hard with cracked anus. Noticed from the clinical case taking that her psychosocial features, her family atmosphere, her environmental factors were likely to have negative impact on her quality of life and on her ability to self-manage this chronic disease as well as to set lifestyle maintenance goals. This was addressed as a priority. In our case taking, we addressed this. Why? What's the negative impact and what is its manifestation? Why this that happened and for how many days that has happened and how she reacts in a negative situations. So everything we have to take care of and we have taken care of. After that, the mental generals, we found the rubrics like this: the desires to be alone, romantic, reluctant to talk, always in a grief due to excessive parental pressure, strict disciplined parents, getting tired easily, brought up in a crowded family where the girl child was neglected, and the physical work pressure was too much, likes to enjoy romantic pictures, grief for neglected love from parents due to girl child but unable to express. So this is the ultrasound report what she brought us on, and that ultrasonography was on 28th March 2011. Normal retroverted, you can see that normal retroverted uterus, anovulatory ovaries, adnexal mass left side close to uterus, and we find really she had endometriotic mass, or that was ectopic, it was in question mark, that was not very clear in ultrasonography, but she had delayed menses, no other symptoms of a pregnancy. And this is the prolactin report. Serum prolactin was 35.88. You can mark that. In non-pregnant girls, it is usually 2.8 to 29.2. But the good thing is if that is within 20, and she had 35.88. Coming to the thyroid profile, we find TSH was 5.16, and as I had discussed that in young age, in unmarried girls, usually if it is within 2.5 to 3.5, we can take it as normal. If it is more than 3.5, it may be taken as the higher borderline according to the different studies available. So then I went for reporterization, taking those rubrics, and I have taken 16 symptoms, and out of that I found that the natramur was leading, followed by sepia. Next was phosphorus, lycopodium, nux vomica, sulfur, staphysagria. So like this. So basing upon this, I went for, and again the past history, she had bleeding piles, family history, diabetes, hypothyroidism, cancer in maternal side. So after reporterization, I went for natramur 200 once in a week for 3 months, along with regular exercise prescribed for the, and the diet habit, the sleep habit, everything was advised. Stress relaxation, mental stress relaxation, everything was prescribed for the patient. So coming to the timeline, including the follow-up of the case, the first follow-up was taken on 24th July 2011. The symptoms were headache intensity reduced, frequency reduced, and the other symptoms as before, mental stress as before. Serum prolactin, as I had told you, 35.88. TSH was 5.16. That is the higher borderline. And ultrasonography revealed retroverted uterus, anovulatory ovaries with endometriotic mass. On 28th March 2011, weight was 68 kg, and medicine prescribed after natramur 200 as the headache intensity reduced and frequency reduced. I went for natramur 1M once in 15 days for 2 months, followed by natramur 10M. Next follow-up was on 27th November 2011. So near about after 4 months, headache occasional, menses regular for 2 cycles, painful cycles, milk secretion from the breasts as before. This was a very embarrassing situation for a unmarried girl, that the milk secretion is there. She was very much again becoming depressed for this condition, feeling very embarrassed before others. So mental stress was as before. I and she brought me again the serum prolactin report of 23rd August 2011, and that one was 44.9 nanogram per ml. Weight was 66 kg. So see, the headache reduced. Mm, She had regular menses for 2 cycles, but again the delayed cycles relapsed, and the milk secretion was as before, and we find the serum prolactin level increased. That means natramur helped to some extent, but the constitution totally is not of natramur. That's why that couldn't take care of the serum prolactin level. That's why the cure rate is not in right path. Next, I went for the intercurrent nosode, basing upon the family history of cancer in maternal side, to carcinosin 1M. Once in 15 days for 2 months. Again, I told the patient to come after 2 months. But the patient came after 3 months. No headache, 23rd February 2011, 12. No headache. Menses delayed for 40 to 45 days. Previously, it was delayed for 60 to 70 days. But now it was delayed for 40 to 45 days. Other symptoms as before. Means milk secretion was as before, and the mental stress was as before. And weight 66 kg, same, stand still. I went for the, as the constitutional remedy might be, thinking over that, I went for natramur 10M. As the no headache was there, so after intercurrent nosode, again to return back to the constitutional remedy, natramur 10M, 2 doses in 3 months interval, I went. So this is the serum prolactin report, 44.90 nanogram per ml. And this is the ultrasound report, what she brought me, where we find the features of PCOD. Both ovaries are enlarged in length, but normal in volume. They show multiple small cysts. No dominant follicles are seen. So the report came as PCOD. Really, this is not a case of PCOD, as there is the serum prolactin level is increased in this case, and that's why we can term it as PCOS. So this is the ultrasound report. Next timeline follow is 15th July 2012. So in 2012 she came with no headache, no constipation. What means is delayed and other symptoms as before, and mental stress was double plus. Next, the ultrasound report I have shown you, that is PCOD. Weight reduction was 2 kg. I went for natriumate 10 m, 3 months interval. So next, the patient didn't came to me. Again, she came to us in 18th June 2014. So got married in 2013. Discontinued medicine for 1 year and 6 months. Avoided conception for 1 year. Husband left home for distance job place, and the lady stayed with in-laws to take care of them for last 3 months. So when the lady came to us, she had delayed menses, relapsed, and scanty menses.
Sorry to interrupt you again, ma'am. Ma'am, the slides are not moving. Ma'am, they are not coming in sequence. Actually, the slide is stuck on the place from the prevalence of PCOD. It's still stuck there, ma'am.
Oh, that means in small screen I have to go. Can you see now?
Yes, ma'am. But the screen is again small. I don't know. There is some technical problem. So kindly, the doctors kindly bear with this problem. They can zoom their own screen and see the slides.
Is it visible now?
Yeah. Ma'am, you can zoom it a bit. It is a bit small.
Okay. But
Now that's okay, ma'am. Yes, ma'am.
I am able to see the 50%. Okay.
This, yeah.
Here with me.
I guess now it's visible to everyone.
Is it visible to everyone now?
Yes, ma'am, it's visible to me. I hope other doctors can also see now.
Okay.
Yeah, it's okay. It's fine, ma'am. Yes, ma'am, you can continue. Thank you,
Shall I
ma'am.
continue now?
Yes, ma'am.
Okay. Thank you. So this is the in 18th June 2014 again. She came with delayed menses, but milk secretion as before, no reduction. But mental stress was not there. She was very happy, very cheerful, with a little bit weeping disposition. She came to us because she was very happy. She was not getting in her parental house the love and affection she got from her in-laws. Though her husband was outside, still then she was very happy. Okay, that's why she remained with them, with the in-laws to take care of them. Okay, the weight, but she gained weight 4 kg, 68 kg, and the medicine prescribed was Pulsatilla 1 m once in 15 days interval for 3 months, and followed by Pulsatilla 10 m. How? Because I went for a refrigeration again. Chest milk in non-pregnant ladies and female genitalia, sex infertility, like that. So delayed menses, mind cheerful, mind weeping, like that. The Pulsatilla came first, followed by sulfur, and I went for Pulsatilla. So next visit, so after 2014 June, she came to us, approached us in 5th January 2016. So near about 1.5 years have gone by that time. So she the statement from her side that staying with her husband and in-laws at a time, she was with all the family members for last 13 months, but no conception. Menses delayed for 5 to 7 days. In the beginning, it was 60 to 70 days. After CPI, it was 40 to 45 days interval. After pulsatilla, it was 5 to 7 days interval. Delayed, sorry, 5 to 7 days delayed. Scanty flow for 2 days. Acrid, but she developed acrid offensive leukorrhea aggravation after menses. Milk secretion relapsed occasionally. That means that has reduced in a pulsatilla, but occasional milk secretion, but again no conception. In between 13 months they had the conjugal life, but still then we had given pulsatilla 10m. With pulsatilla 10m the interval reduced, the milk secretion reduced, but no conception. So again the case was reviewed. Why there is again some obstacle. I thought there might be some problem, some obstacle, we have to find out that. So again the case was reviewed. Repeated cold attack was there. Mental symptoms recognized indicating indifferent to everything, even to sex due to tiredness. Has no because her in-laws, her husband, everybody was with her, and she was the only member to work for the to handle the whole work of the family. Okay, so has no desire for any work but does forcibly. Good moral sensitiveness, no emotional attachment, responsible, weak, tired feeling. I must say here that she was becoming very tired due to her family family work throughout the day, and she has no energy for sex at night, or to uh, say good words to others, to play with others, to laugh with others. She has no, she used to have no energy during that time. So, what she explained. If we will discuss to some bit of mathematica in this state, that Catherine Coulter writes in a very good explanation of sepia psychoanalysis. In psychoanalysis, Catherine Coulter has written in sepia that we find, that is a female remedy, we know that we find three types of ladies in sepia. Number one variety is the overworked, wretched housewives or emotionally withdrawn women. Why she becomes emotionally withdrawn? Due to the overburden of the family. She has to take all the responsibility, all the physical works she has to do for the family members. And with that, uh, again in this case we can think of that she might have told that no, I can't do all these things, I have to stay with my husband only, I can't adjust with others. But she has not told like this. She is not a escapist in this manner. She has good moral characters, good moral sensitiveness, she is dutiful. So sepia is like this. She is dutiful, very good moral sensitiveness is there. So she works, she will not escape, she is not an escapist. So like others. So but in this case what we find, the lady was like that. Second variety sepia ladies are usually the career contented women. The lady is very much career oriented, very much career contented. So that's why she becomes very indifferent. In the Kent's repertory, we will find in under indifference, we will find sepia is in first grade. So why sepia becomes indifferent? These are the explanations which is given, described very vivid manner in descriptively in the case of Catherine Coulter. He has written like this, that the number two variety is career contented woman. So what happens in that? The career contented woman is very much busy to build up her career. She thinks that other things are not so useful, is should not be involved, should it is the wastage of time. So she thinks like this, that why she becomes very indifferent to everything. And the number 3 variety is a dissatisfied complainer. So like tuberculinum, we will find she is very much dissatisfied with every event, and the complaining nature, again in Kent's report we find CPI in second grade, the for complaining nature. That's why, so in 3 varieties, and this lady, in my view, coming under the first variety, that is the overworked, wretched housewives who is emotionally withdrawn women. That's why she becomes very indifferent, and indifferent also to everything, even to sexual affairs with her husband, sex with her husband. Also, she was very indifferent. This indifference also we find in case of natramure, in case of phosphorus, we find indifferent. Okay, equally, in equal gradation, we find. So, but in case of natramure, we find indifferent to pleasurable events, not in every way, not to the family members, not to the relatives. So, not she is also, natramure is also very morally conscious. The Catherine Coulter has written that if he is a son, he will like to take a rented house just adjacent to his parents, because he can take care of their parents. So, so much morally conscious, dutiful, just like Scipia. But in case of Natramure, we find indifference only to enjoyment, only to pleasurable events. But in Sepia, we find to everything. Even whom she loves best, he becomes indifferent. But in case of Sepia, there is, she has love and affection inside. She is very conscientious. So the love and affection is there. It is not there, it's not like that. It is there, but the manifestation is benumbed. So she can't manifest. She has no energy. Because in Allen it is written that even if they put on the dress also, she sits on the chair. She has no energy. She kneels down in the church because she has no energy. Energy level is too low in case of Sepia. That's why she, the mental reflection, the manifestation of love is benumbed in that case. In case of phosphorus, we find indifference, but that is very peculiar. How woman, our mathematica is so good in the personality study. That is in phosphorus, in primary stage, the phosphorus is soric. Okay, and the pathology is also soric. In that case, we will find that the pain in stomach, the heartburn, aggravation in empty stomach, relieved after eating, just like that. Uh, but when the disease process proceeds after years together, the pathology proceeds simultaneously. In physical, accordingly, mental sphere also proceeds. The soric miasm is transferred to tubercular. So in a secondary phosphorus, we find tubercular miasm. During that period, we find the why that happens might be due to some betrayedness, some grief, like that. The primary phosphorus, the soric phosphorus, is now becoming the tubercular phosphorus. So in tubercular phosphorus, we find the Allen has written the tubercular phosphorus manifestations. That is the what we find: indifference, apathy, taciturn, gloomy, has no desire to talk, nor she doesn't want to listen also. Okay. So in that is the phosphorus indifference with a huge time gap. But in case of sepia, always indifference in first grade, that is for everything. And in this case, also the girl was so romantic, and now she has aversion to sex. aversion to family members. So all these indifference uh, put some input to me that why not to CPR, because in the first reporterization sheet you will find that number one drug was natramur and the number two position was CPR. So basing on that, I went for CPR 200 once in a week for 3 months, where the TSH level again 6.32, but prolactin reduced to 28.99 in this case. So this is the report. You will find this. Next is 16/6/2016. No conception for last 1.5 years. No milk secretion for last 4 months, but very indifferent. Too much tired. No emotional concerned for anyone. Name the again investigation reports say TSH level was 3.75, prolactin more reduced 11.68, so quite normal on dated 18th June 2016. Weight also reduced to 58 kg and but no conception. So in that case I went for Medrinum 1M as a antipsychotic drug nosed intercurrently. So Medrinum 1M once in 15 days interval followed by again Sepia 1M and followed by Sepia 10M. With frequent outings for mental relaxation and all those prescribed regular exercises, sleep habit, good sleep habit with diet, all these things. So next the lady came to me with 15th June 2017. Okay, and she said with the symptoms of pregnancy after 20 weeks. TSH was at that level 4.92 and Sepia 10M again prescribed with fractional doses and 1 teaspoonful once in a week with iron, calcium, protein, all these things. Because this is my practice for last 20 to 23 years. I am doing this work that during antenatal period, I am continuing with the constitutional remedy, taking the totality of the case, and I do the antenatal checkup in our clinics with the ultrasonography intermittently whenever necessary, all the investigation reports, and we refer the case for labor to a medical center or a gynecologist, like that. What the patient, according to the patient's choice. So within the last 23 years, I might have seen pregnancy about 2500 plus cases, but till today no case is detected with congenital anomaly, no case with autism, no case with ADHD. So it gives a hypothesis that the constitutional remedy really works during that period for a mentally healthy and physically healthy to bring up a physical and a mental healthy uh, child. So the more research is needed on this case. I can't say this is the rule, but this is the hypothesis. What I am saying, depending upon this much of cases. So this is the TSS level, prolactin 11.68, and she had all routine checkups of investigations. All were too good. Hemoglobin was little bit low, and with this, again, this is the beta gram index. Uh, no, this is the SCG report, beta SCG report indicating 1933. The value was which indicates pregnancy, positive. Again, this is the next ultrasonography report she brought to me. That is the single viable fetus of around 12 weeks, 6 days maturity. Next ultrasound, toxoplasma antibody IgM was negative. All torch factors were seen and those were negative. And this is the next ultrasonography report. Single live fetus of 20 weeks, 3 days of fetal growth. No obvious congenital anomaly in TIFA. And this is the TSH level again gone 4.922. On 8 February 2019, she came to us that delivered a male baby, normal vaginal delivery on 30th October 2017. And no complaints in last 2 years. Periods, menses were very regular and no headache, no constipation. So, but at that time, she had the TSH level was increased 10.35 and advised for lifestyle modification as along with the Sepia 10M. Also, I had given her thyroidinum 3x twice daily to continue, but after that the lady didn't came to me till today. Okay. So this is the, again I see, you see the serum prolactin, I, due to my inquisitiveness, I sent her to go for serum prolactin, that was 4.38. So which was raised up to 44.999, that has reduced to 4.38 with the homeopathic constitutional remedy. Okay. And the testosterone level also was too high, and that was also reduced to quite normal level 12.98, and insulin was very normal, that is 0.50. So this is the report what we have gone through. So this is the coming to the discussion already made. So lifestyle management is very important associated with homeopathy constitutional remedy. I can say because in many cases I have seen that the lady weighing 90 kg, 95 kg, 85 kg, 80 kg like that, if the lifestyle is not managed properly, even if with homeopathy constitutional remedy, it becomes very difficult to convert a infertility to fertility. And only with lifestyle management also I have seen the cases, it is also very difficult to convert infertility to fertility. So both the things have their values in their own place. So that's why the lifestyle management along with yoga, meditation, exercise, sleep habit, good diet habit with mind relaxation along with homeopathy constitutional remedy is in my view is the answer for PCOS associated with infertility. So this is the discussion already. I had made all these discussions. In profound grief also seizures menses in case of Ignacia, Natramur, Sepia. And again the literature writes that the Calcarea, Natramur, Sepia, Medrinum are the very good drugs for infertility. And aversion to sex also we find in case of Sepia, which is a reverse of phosphorus. See, again phosphorus is indifferent. Pulsatilla is also indifferent, but aversion to sex is not there in case of phosphorus and pulsatilla. So manifestation of love, we find phosphorus. See how beautifully the Mathematica describes, that is the phosphorus and pulsatilla. The manifestation of love is easily pour out affection and cares. Natramur provides instruction, instinctively assuming the role of a teacher. She loves, but role of a teacher like instruction. Calcarea indulges her children and enjoys them in an effortless empathy. Arsenic enjoys taking commanding voice. The love is manifested through command. Sepia, love is a burden to her. Okay, she doesn't love is not like that. The manifestation is benumbed, so that's why she can't express. That becomes a responsibility, a burden to Sepia. And Lycopodium will forsake his family, but never feels guilt or regret. So in this way we can define love also, we can differentiate love in case of different drugs. So this is the conclusion, that she conceived and delivered a male baby, normal vaginal delivery on 30th October 2017. So this is the final message, that is the what I have told, the meditation, yoga. Yoga means that might be aerobics, that might be in a gym, that might be dance. So whatever you like, meditation, you may sing. So mind relaxation, good sleep habit, and the exercise, good diet, along with homeopathy constitutional is the answer to PCOS. So this is the summary. Coming to conclusion, these are the references I have taken. This is the informed written consent form signed by the patient. Thank you. Thank you for patient hearing. Any questions, please?
Uh, thank you, Dr. Sumana Kumari Panda, ma'am. It's really a beauty of homeopathy you have shown. because you're believing in homeopathy philosophy and stick on to the materia medica, taking the case in detail and connecting all these things together, and still whenever there is struggle for moving forward, then you use the complementary as well as the anti-psychotic or anti-psoric remedies to help the constitutional remedy, and that really works in the case. And that's so when you stick on to sepia, you didn't get the result in a short time, but you just waited and waited and then changed the potency, and then you went up to give medorinum to her, and then you rise the potency to 10, and then you got the result. This is what homeopathy philosophy is all about. This is what our materia medica is all about. And you need to study and differentiate all those medicines because of your immense knowledge in materia medica that really made you to stick on the sepia itself. And that's how the result, such a brilliant case with so much of problems in hormonal level was corrected. Not only the hormonal level were corrected, you got the result. That is what is the baby, a male baby, a child is something great that you have produced. As you rightly pointed, you have case histories of more than 250 cases of successful cases.
2,500 and more than 2,500, might be near about 3,000 cases.
That itself is has shown the power of homeopathy. And congratulations, ma'am, and those who want to participate in the session. We can have some more presentation.
Sir, one question is there in the chat box.
Yes.
That from Dr. Annie Jan, that protocol
that's
for
a big
pregnancy.
question. That's a big question, and the protocol need to.
No, you can say that the totality of the symptoms is the case taking. Proper case taking is the real answer from where we can proceed to totality of the symptoms. But the pregnancy anomalies, in yesterday session also someone asked me about the CMV, cytomegalovirus IgG infection. So that is also coming under pregnancy complications. So that's why if in next session, if that will be permitted to me, then I can go for the pregnancy complications with the torch infections. So, and I am having very good cases, near about 5-6 cases are there. So
I am inviting another button, Dr. Ramadevi Ambari. It just a few comments on this session, madam. Please come. She is also having more than 2,000 cases, successful infertility cases in her kitty.
yes,
And she is considered to be a mother for those children as far as the patients are concerned.
very good, very
I'm
good.
ready. I'm ready, madam. Please unmute. No. I think there is some problem. So now I invited Dr. Neha Kakar to say vote of thanks to Dr. Sumana. Madam.
Yes. Yeah, it was a from Dr.SUMANA ma'am. She presented a very beautiful and very well taken case where all the nitty-gritties of case taking were taken into account, and the case was also repertorized beautifully, and anti-miasmatic prescription was also made. So this is the basic method that all the homeopaths need to follow while taking any cases. And obviously the PCOS is emerging. PCOS and PCOD is emerging as an epidemic especially in the young girls, and many females are experiencing infertility issues due to that. So homeopathy can play a very major role here in removing and treating these kinds of diseases. So also in future, like ma'am was saying, we can have more sessions from her where she can share her wonderful experiences with our doctors. Thank you so much, ma'am. Hope to see you again, ma'am. Thank you.
Thank you, everyone.
Thank you, Dr. Sneha. Now, tomorrow we will have a session from Dr. Balachandran, and so we'll be talking about importance of biochemic medicine in practice. And with that, we come to the end of day 1281. And it's thank you all. Thank you.
Ganesh, I had some net problem. I was not able to unmute.
Okay.
Okay. Okay.
Okay,
The
if you
class
want
was
to say
very
something,
nice. It was very nice.
Thank you, madam.
okay,
I was not able to unmute.
okay, you are
I am
called.
also interested to listen to you, madam.
Okay. By God's grace.
Ma-
Let us.
Madam, as well as Ramadevi Ambadi, Madam, as well as her daughter, presented so many presentation in this forum about infertility and so, particularly the complaints of women.
Dr. Danis, I want to request you please share all the videos of presentations in YouTube so that
Yes,
I
yes,
can
yes. We are uploading all those things, and those who want to watch our videos, you can watch the today's presentation tomorrow itself, and some of the videos, previous videos, are also uploading day by day basis by Dr. Hubert, and that will be uploaded soon. And don't worry about that. Definitely, your videos will be uploaded.
Thank you.
Okay,
Thank you.
madam. Thank you very much, and those participating in the session also. With that, we come to the end of the day, 1281. It is over to Dr. Shaila to moderate the Malayalam session. Thank you all. Right.
Thank you. Thank you.